Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled Vaccinations and Rare Neuroimmune Disorders. My name is Erin Coriel, and I will be co-moderating this podcast along with my colleague, Gigi DeFibri. The TMA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at mylitis.org. This podcast is made possible in part of the generous support of Alexion Pharmaceuticals Incorporated. Alexion Pharmaceuticals is a global biopharmaceutical company focused on serving patients with severe and rare neuro disorders through the innovation, development, and commercialization of life-transforming therapeutic products. Their goal to deliver medical breakthroughs where none currently exist is driven by the knowledge that people's lives depend on their work. This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar.
Thank you, Erin. I'm Gigi DeFibri. For today's podcast, we are pleased to be joined by Dr. Augusto Miravalle and Dr. Terry Schreiner. Dr. Miravalle is an Associate Professor of Neurology, Associate Chair for Education, and Chief of the Multiple Sclerosis Division at the University of Florida College of Medicine. He subspecializes in multiple sclerosis and related neuroimmunological disorders of the brain and spinal cord. Dr. Miravalle has been involved in both clinical and basic science research. Before moving to the University of Florida, he served as the Residency Program Director and Vice Chair of Education, Chair Clinical Competency Committee for the Residency Program, and Chair for the Adult Residency Education Committee for the Department of Neurology at the University of Colorado. Dr. Miravalle received his medical degree at the University of La Plata, Buenos Aires, Argentina. He completed his neurology residency training at Loyola University, where he served as Chief Resident of Education. He subsequently completed a clinical neuroimmunology fellowship at Harvard University. Dr. Miravalle was the recipient of the 2012 American Neurological Association Medical Education Fellowship Award. Dr. Schreiner is a neuroimmunology specialist and pediatric neurologist at the University of Colorado and Children's Hospital, Colorado. She subspecializes in pediatric onset demyelinating disorders of the central nervous system and has begun a multidisciplinary clinic for children with these disorders. Dr. Schreiner sees patients at both the Rocky Mountain MS Center at the Anschutz Pavilion of the University of Colorado and at Children's Hospital, Colorado. Her areas of interest include immune-mediated neurologic disease, spinal cord syndromes, including acute flaccid myelitis, quality of life in pediatric patients with demyelinating disease, biomarkers of multiple sclerosis, and clinical trials. She earned a master's degree in health policy and administration. Dr. Schreiner also worked in healthcare consulting for several years prior to her career in medicine. So thank you both for joining us today and welcome to the podcast. We very much appreciate you joining us today.
Thank you. Great
to be here.
Great, thank you. So to begin, we did receive a lot of questions from the community, and so we did kind of try to group them together in themes to be able to get to as many of them as possible, and people can still submit questions via GoToWebinar as well. But to start, Dr. Schreiner, would you mind just giving us an overview kind of vaccinations and rare neuroimmune disorders, and if there's any theories that could explain an association, if there is one?
Yes, absolutely. Well, first of all, let me again thank you for including us in this discussion. I think this is an important discussion to have and something that comes up for me in clinic and talking with my patients and their families quite frequently. So I'll start by talking a little bit about what vaccinations are and then extrapolate into how they work and why they are questioned to be a factor in the development of transverse myelitis and other neuroinflammatory disorders. So in any discussion of vaccinations, I feel like we need to start with the benefits. And the benefits are that vaccines have, in some cases, eradicated or near eradicated diseases that formerly caused mass death and illness and death. And so there has been a tremendous role for vaccines in our history and really have contributed to much of the healthy living that we have today. They work in various different mechanisms, and we have different groups that we put the vaccines in to, and the groups are constructed according to how they work. So, for example, we have live vaccines, and we know like varicella, yellow fever, rotavirus are all in this category. We have another whole category of vaccines that are called live attenuated. They are vaccines in which the virus causing the disease that we're trying to prevent has been changed in a way that makes it no longer able to cause the disease, but able to trick the immune system into thinking that it has seen that disease and therefore knows how to fight it. And then we have some other varieties that include conjugate vaccines, which are combinations of proteins and different elements of either bacteria or viruses that we're trying to prevent from causing infection. So what each of these categories of vaccines do, what vaccines do is prime our immune system, make our immune system think that they have seen this invader before and they know how to fight it. And our immune system is smart. It has a long memory. It knows and can respond to an invasion of something that it has seen before very quickly. And the vaccines work by maximizing this, introducing something into our body that triggers our immune system in a way that it believes it's fighting an invasion when in fact we're really just teaching it how to fight this particular virus. So if we are exposed to that virus or bacteria in the future, our immune system is like, okay, I've seen this before, I know exactly how to fight this and therefore prevent illness. So that is what vaccines do. The reason there has been such, I guess, inquiry and interest into exploring whether or not vaccines may be the cause of an immune-mediated problem is that there is this thing called molecular mimicry. And what that means is our immune system responds to particular sequences of proteins. It's sort of like the signature, how it recognizes what it is fighting against. If the signature on one virus matches the signature on a protein in our own body, then the immune system can get confused and say, oh, well, I know that if I see this signature on that particular, if I see that signature, then I need to rev up production of antibodies, of cytokines, I need to fight. But if that signature is similar to something on our own bodies, our spinal cord, our neurons, then the immune system actually can cause damage to itself. And that is molecular mimicry. So this is the way in which, or the reason that there is what we call biologic plausibility. There is a possibility that vaccines could have this effect. And we'll talk much more about what the evidence has shown us and how this plays out in our scientific querying into whether or not this is in fact what happens. But there's the theory behind it, and there's another theory of something we call a super antigen, and that just means, well, there's some things that can rev up the immune system to a normal degree, and there are other things that can trigger an all-out assault, and those are super antigens. And might there be something like a super antigen that could trigger our immune system in a maladaptive way as well? And so maybe I'll pause right there and see, Augusto, if you have anything to add.
Absolutely. Thank you, Terry. And you know, that was a very eloquent description of the mechanisms behind the potential trigger of neuroimmunological disorders as a consequence of vaccinations in this case, but the truth is that that could happen from any time the immune system is exposed to an antigen. And just to expand on what Dr. Schreiner explained before, so as you mentioned, vaccines are a way to, in a sense, manipulate the immune system to think they're being exposed to the real disease. And the purpose for that is to obtain this benefit of immunological tolerance, meaning that then you're training the immune system to be ready to respond to certain antigens in a way that might protect against disorders. What happened is that in certain circumstances, through the mechanism Dr. Schreiner explained, you are creating also a pool of immune cells or lymphocytes that will have the ability to respond to self-antigens as well. And that's the basis to explain many of the autoimmune disorders, including transverse myelitis, multiple sclerosis, neuromyelitis optica. So the question here is whether the use of vaccinations is linked to these disorders in a way that is different or increased from the natural infection that the vaccinations are trying to prevent. And that's where the evidence argues against the evidence that vaccines are more harmful than the disease that are trying to prevent. So virtually all of these reports that you see that for the most part are case reports of neuroimmunological disorders that come after vaccinations, they're also present as a consequence of the infection that the vaccination is trying to prevent. And so the question here becomes, is that a factor that is directly linked to the vaccine itself, or this is a factor, a response that the immune system is doing, perhaps a maladaptive response, that the host of that infection, whether it's the individual who has the disease, is not able, their immune system is not able to discern between the subtleties of the antigen present in the vaccine or the infection and the self-antigens. So that's the basis behind this, that perhaps some individuals have an immune system that has been developed to the point of discerning between those subtleties. Some individuals may not. And that's why, even though these reports are real, for the most part are rare disorders. You have thousands and thousands of individuals receiving vaccines, and only a handful will have these neuroimmunological disorders associated with them.
Thank you very much, Augusto. So several of our members reported that they were diagnosed with a rare neuroimmune disorder within a few weeks of getting a vaccination. So what would be the time frame for which an association could be likely?
Okay, well, I'll jump in and talk to that one a little bit, and then Augusto, I'll have you, as before, sort of comment as well. And so I think there's some issues in this question that I want to address sort of separately. So one is we all know of case reports in which, and maybe we ourselves know, our loved one, a friend, a colleague, someone who has had a vaccine and then within a period of time has developed a rare neuroimmunologic disease like transverse myelitis, like optic neuritis, multiple sclerosis. And the question is really, is that causal? It's so, I think in many ways tempting to say, one thing happened and then a subsequent event happened, therefore the first thing caused the second thing. And that's really what we have tried to investigate in the research that has been done in this area, is the temporal association actually causal? So many people will joke and say, "Oh, well, I know it's going to rain tomorrow because I took my car to the car wash today." And so that would be something that may be temporally associated. Maybe sometimes we go to the car wash and it does rain the next day, but we haven't actually caused the rain by going to the car wash, as much as it might feel that way. And I offer this example not to minimize any of this, but just to sort of illustrate that sometimes something comes before an event that is not actually causing that event. Now, with that being said, in the context of plausibility, is it plausible that a vaccine could trigger a rare neuroimmunologic disorder? There is a time frame that we think about. We know basically how the immune system, we think we know how the immune system works or responds to a vaccine, and that is, generally within a couple days we are producing antibodies. We know that the number of antibodies that are produced, for example, after a vaccine peaks around 2 weeks, and we know that when the immune system is being triggered to attack, the cells divide very quickly, on the order of once every 6 hours or so. So if we take these things into account and we say, okay, so if the immune system were triggered by a vaccine, what is the time frame in which we would expect to see a sequelae? We think generally about, a few days later, maybe up to 5 days to a month. In the studies that have been done, and there was one just recently published by an author named Baxter, that his group looked at a 5 to 28 day window following vaccination in a large group, a group organized through something called the Vaccine Safety Data Link. And they looked at something like 63 million vaccinations within a period of time, and they said, okay, well, let's look at the people in this large population that developed something like transverse myelitis and look at the 5 to 28 day period before their presentation and see whether or not there was a vaccination in that time period. They also broadened their scope and said, okay, well, maybe that's too narrow. Why don't we also look at a time period of 2 days following vaccination to 42 days? So they made the window a little bit broader. And in this particular cohort, where they were looking at people who developed TM in a period of 5 years and then trying to compare whether or not they had received a vaccine to everybody else in the cohort who had been receiving vaccines but did not develop TM, they found that there was no association. So I know I'm jumping ahead a little bit to talk about one of the specific studies that has been done on this topic, but to answer the question of the timeline that we would think about, I generally think about that window of maybe 5 days to 28 days after.
I agree with Dr. Schreiner, and just to expand on that, the way we look at some, if not most, neuroimmunological disorders is looking at a multimodal situation in which multiple factors play a role in triggering and initiating the disease. For the most part, whether you look at transverse myelitis, multiple sclerosis, neuromyelitis optica, it's not that we have a single factor that is responsible for causing the disease. So there are genetic factors, there are environmental factors, and there are factors that actually relate to the host itself. And in this case, I want to emphasize the fact that there are certain individuals that are more susceptible for the development of autoimmunity. And you see that through even disorders outside neurology, whether it's asthma or lupus, and even some of these disorders actually run in families. So the thought behind that is that independent on the trigger, these individuals have an immune system that is more prompt to respond in a way that may not only protect against the antigen that they are trying to fight, but also cross-react with self-antigens. Whether it's because these immune cells, as I mentioned before, they're not sophisticated enough to discern between molecular differences between cells and foreign antigens, whether it's because the regulatory cells that are intended to prevent autoimmunity from happening are not working well, whether the process of initial immune tolerance that happens when we are kids, it's been somehow interrupted. So there are many factors, but the truth is that the current thought behind these disorders is that the immune system already starts by being more prompt and predisposed to react in a way that is maladaptive and conducive for autoimmunity. So the question becomes, still something has to trigger that. Something that has to be an event that is going to activate these cells that we know these individuals have, and we call them autoreactive cells. So why all of a sudden transverse myelitis occur in somebody when they're in their 50s? If you're thinking that these cells have been present there for their entire life, what triggers those cells to all of a sudden get activated and cause disease? And that's where the role of vaccines may play a role, but it's not unique to vaccines, right? So we know that infections can do that, and that's why we have an entity that we call post-infectious transverse myelitis, post-infectious encephalomyelitis. So there are these entities that we labeled based on what we know of, not only on the disease itself, but sometimes when possible based on what triggered that. So if there is a role, as Dr. Schreiner mentioned before, of biological plausibility between vaccines and disease, is perhaps as a trigger, but not as the cause.
Great, thank you. And this is, I think, related to what you just mentioned, Dr. Miravalli. So one of our listeners wrote in, had I not been stricken by this vaccine, in this case, the flu shot, would something in the future have gone ahead and had a similar effect, I guess, with their diagnosis? So if you could just address that.
Yes, and actually the flu vaccine is one of the exceptions, because for the most part, we tell individuals and patients who suffer from these side effects, well, if you had a bad reaction to any vaccine or any treatment for what it comes, don't do it again. Because, when you look at these large studies, there is, for the most part, no increased risk. But if you look at individual cases, if somebody had an adverse reaction to a vaccine, for the most part, I recommend to avoid revaccination with the same type of vaccine. Interestingly, the flu vaccine is one of the exceptions, and the reason for that is because the way the vaccine is being manufactured is trying to mimic the strain of the seasonal virus. And as we all know, the virus itself mutates every year, and the strain differs. So when you manufacture the vaccine, you're trying to mimic the strain of the virus that you're expecting to have in that season. So that's why you see that even if you had reactions to the flu vaccine in prior years, that doesn't necessarily mean that you may have similar reactions in the future. And this became very clear with the now famous pandemic of a flu in the 70s, in 1976, that there was a large number of patients who developed Guillain-Barré right after that. And there were numerous studies looking at that serious disease after vaccination with flu. And the latest one came from the Sweden, a national database. They looked at over 2 million individuals, and they could not identify any increased risk of Guillain-Barré with the current strain of H1N1 or flu vaccine. So that may be one of the few exceptions, but for the most part, we tend to recommend do not revaccinate if you had an adverse reaction before.
Right, and I'll just add to that. I agree, absolutely. And to go back a bit to the discussion about how there can be many triggers of disease, multimodal factors involved in triggering something like TM, and how that it may not be one thing that causes a disease, but a trigger that tips the scales that were, predisposed towards that, so to speak. And we think about genetic predisposition towards autoimmunity. We think about environmental exposures. And so if the question was that was posed was, if it hadn't been this one immunization that triggered my TM, would it have been another? I think there is a possibility. I think there is a argument to be made to say, yes, in a predisposed individual, in someone who already had certain features that were making an inflammatory response more likely, the trigger could be one thing, or it may have been the infection that happened the next month, or the immunization that happened, years from now. It's really difficult, if not impossible, to say that, but I think there is a rationale, a mechanism behind saying yes, in a predisposed individual, it could be one of any number of triggers that actually tips the scales and causes the disease.
Thank you very much. And I know, Dr. Shiner, you mentioned earlier about live vaccines. So is there a difference between live vaccines and other vaccines? I think you might have kind of spoke to that earlier. And are there recommendations for people with rare neuroimmune disorders?
Okay, yes, I can address that. So I did speak a little bit in the very beginning about how there are different types of vaccines, different ways in which the vaccine is made to subsequently trigger an immune system into thinking that it's fighting a disease, when in fact we're just teaching it how to fight a disease or a virus, an infection. And so the live viruses are one type of vaccine, and it is not, and the more proper term would actually be live attenuated, meaning that we take the virus and we change it in a way that it is not able to cause disease in an individual when vaccinated with that virus, but it is able to teach that host, that person's immune system, how to fight the actual live virus. And so a live attenuated vaccine is a vaccine that is it comes from an actual virus, but it's been weakened, it's been changed so that it should not cause actual disease in somebody with a normally functioning immune system. Now, there are exceptions, unfortunately, to that in history, where we go back to look at the oral polio vaccine, and that did cause paralysis in a subset of people who received it, unfortunately. But that is the exception. The standard with live attenuated viruses is that they do not cause infection. They just teach the immune system how to fight it, and oftentimes have a greater duration of protection than some of the other viruses, vaccines. So we have killed viruses, and these are killed vaccines. They're vaccines that come from viruses that, you can guess, have been killed, have been changed in a way so that they promote an antibody response in the host to give temporary immunity against something like influenza. Pertussis is another one in this category. Rabies is in this category. Something that hopefully many of us will not need. And then the third category is I'll combine something called conjugate vaccines as well as recombinant vaccines. And these are vaccines that are created by taking certain aspects of the antigen of the invader and attaching it to a protein that helps the immune system respond more effectively, more vigorously against the would-be invader. And so in this category, we have pneumococcal conjugate, we have meningococcal vaccines, hepatitis B is a recombinant vaccine. And so each of these different mechanisms is to achieve basically the same thing, which again is to teach the immune system how to fight an invader that they have not actually seen before. Augusto, do you have anything to add there? Yeah.
Absolutely. And a question that I often get asked is, but if the live virus vaccine or the attenuated virus vaccine carries a slightly more risks of developing the disease or mimicking the disease it's trying to prevent, why do people still use that? And I always like to use this comparison. So look at your immune system as the police in a city, right? So you're trying to train the police, which is your defense mechanism, to learn how to recognize a criminal. So if you only show the police a fingernail of the criminal, they might not know who to chase because it's only a little piece of the body of evidence. But if instead of that you show them a picture of the person with a face, they might be more specific in order to mount a defense mechanism against that. So in vaccine manufacturing processes, it's this balance that you have to play between how much of the antigen you show or you expose the immune system to in order to mount a stronger immune response or a more accurate immune response versus how much risk you introduce to the host of potentially creating the disease you're trying to prevent. And that's why different models of vaccines will call for different protection against the disease you're trying to fight, as well as different risks.
Okay, great, thank you. And so I know we've talked about this a little bit, but so if someone was diagnosed with something like TM, but they wasn't after a vaccination, is having just a rare neuroimmune disorder a contraindication to getting vaccinated? And then, what if their doctor recommends that they don't get vaccinations?
Terry, you want me to address that, or?
Yeah, why don't you go first on that one?
Sure. Yeah. So basically, as we mentioned before, so if there is a clear temporal relationship with a side effect or adverse event from the vaccine that causes a complication in a patient, I usually recommend the patient not to do the same vaccination again, with the exceptions that we mentioned before with the flu vaccine. For individuals who already have an autoimmune disorder, and there are two things that we have to take into account. One, as we explained before, because of the nature of their disease and their immune system, they might be more prompt to develop an autoimmune response after being exposed to certain vaccines. And that's why, for example, in multiple sclerosis patients, we try to avoid the use of live virus vaccines when possible. The example being, for example, the intranasal flu vaccine. It's a live attenuated virus vaccine, whereas the intramuscular flu vaccine, it's a killed vaccine. So we always recommend to use the intramuscular when possible and avoid the use of live virus vaccines. The other consideration that we have to take into account in these patients is the fact that for the most part, they are also receiving immune suppressive therapies to control the disease. So then you're talking about a different level of complexity, which is in an individual who has an underlying autoimmune disease that is now on treatment with immune suppressants. And two things can happen in that scenario. One is that the immunity that you're expecting to generate by exposing the vaccine to this individual might be weakened by the fact that the immune system is not competent. So even if you vaccinate individuals who are on immune suppressive medications, they might not mount the level of immune response to convey protection. The second consequence will be that because the immune system is weakened, they may develop the symptoms from the disease that you're trying to prevent. So for the most part, individuals who are receiving immunosuppressants, we try to avoid live virus vaccines, as we mentioned before. And when possible, we try to coordinate the use of certain vaccinations prior to starting immunosuppressive medications.
Mm-hmm. Yes, well said, and I agree. And I will sort of point out again to cycle back to the discussion about influenza and particularly in the disease multiple sclerosis, which is a disease characterized by ongoing inflammatory effects and attacks. There is more risk to be, there's more risk associated with getting the infection of influenza than there is with the vaccine of influenza. So I want to just point that out, that not only that multiple sclerosis is much different than an idiopathic transverse myelitis, in which we think it is a one-time event, not to occur again, and a disease like MS where there can be ongoing relapses over time, and concern specifically in that disease about whether or not to vaccinate against something like the flu. And again, I agree, Augusto, with you, and the evidence supports that the infection can be much more significant and detrimental to the patient than the vaccine itself. And so if I may, I'll talk a little bit more about transverse myelitis and idiopathic transverse myelitis. And myelitis itself is a broad term that refers to inflammation in the spinal cord that can come from many different etiologies. But to look specifically just at idiopathic transverse myelitis, which we believe to be a one-time event, should those patients go on to receive vaccinations after that? And I believe, and the evidence would support, that the answer is yes. You should continue to be vaccinated. And there was a time, I think, in which we thought, well, if your immune system is prone to overreacting, as evidenced by this one-time event of transverse myelitis, perhaps we shouldn't give live virus vaccinations. Perhaps we shouldn't give vaccinations. But truthfully, the evidence is that there is not an associated risk of having additional myelitis events or other demyelinating events after a transverse myelitis when vaccinations are given.
Yeah, and just to second on that, particularly true when you're looking at older individuals with the concern around pneumococcal vaccine. And just to expand on that, the risks of acquiring pneumococcal infections are larger and more detrimental than the potential and small risk of developing complications, let alone the fact that this is a kill inactivated bacterial vaccine. So the risk itself are minimal. And when you're looking at immune suppressed individuals or individuals over 65 years of age, the risk of complications and sometimes fatal complications from the infection itself outweigh the risks of the possibility of complications.
Thank you both so much for that. So we had a question come in, and it reads, I'm a 68-year-old female with NMO on Rituxan. What vaccine should I take and when as it relates to infusions? And what about with steroids or other acute treatments?
Augusto, maybe I'll let you address that one.
Sure. As we mentioned before, so we try to vaccinate patients, particularly with the intramuscular flu vaccine. When indicated in individuals over the age of 65, they should receive the pneumococcal vaccine. There are two types of vaccine. The conjugate vaccine that is usually used for anywhere from infants to elderly individuals that confers immunity to 13 strains of the bacteria. That's the Prevnar. And then you have the polysaccharide vaccine, which confers immunity to 23 strains of the bacteria. So for the most part, that's a pneumovax. For the most part, individuals that are 65 and older should be vaccinated with a pneumovax vaccine. And just as I mentioned before, in order to even minimize the already small risk of complications, when possible, I try to coordinate all these vaccinations prior to the initiation of immunosuppressive therapies. If a patient is already on a medication and needs to be vaccinated, it really depends on the medication they're receiving. With rituximab, the biological half-life of the medication, it takes up to 3 to 6 months for the B cells to restore to their baseline levels. So it will be safe eventually to wait until a week or two prior to the next infusion to administer these vaccines. For example, in the case of MS patients receiving fingolimod, which is another immunosuppressive medication, we usually have to interrupt treatment for at least 4 weeks, vaccinate if needed, and then wait an additional weeks, a couple of weeks to restart the medication. So it really depends on the medication a patient is receiving, but for the most part, when possible, we try to coordinate timing and try to prevent as much as we can both situations, the immunosuppressive lack of response to the protection of the vaccine, as well as potential complications.
Okay, great. Thank you very much. And we got another question that their TM was, one of our members asked, stated that their TM was apparently an attack on indolent herpes zoster, chickenpox, that was in their cervical spine. And is there any sort of risk for taking a shingles vaccine, since it was, the initial event could have been related to chickenpox? Dr. Schreiner?
Yeah.
Or Dr.
Well, yeah, I think I suspect that this question was actually about varicella zoster, which is the chickenpox virus, and that can reside in a very specific part of the nervous system called the dorsal root ganglia. But I think I might ask Dr. Miravalle to answer this question as a adult neurologist.
Sure, and so the zoster vaccine, again, is a live attenuated vaccine. For individuals who had prior exposure to the virus, often individuals remember, and they had symptomatic infection in the past with chickenpox. For the most part, the revaccination with the zoster vaccine is safe, whether you have or you don't have an underlying autoimmune disorder. The question becomes in individuals who never been exposed to the chickenpox in the past, and that's usually when we try not to expose patients to the zoster vaccine. Just to give you an example, the medication I mentioned before, fingolimod, the type of immune suppression that the medication will result will increase the risk of reactivation of or a large immune response to the exposure to these type of viruses. So for that, the FDA requires that patients have to be vaccinated prior to initiating therapy. And in that case, what we do is we vaccinate individuals who've never been exposed to the virus with the varicella vaccine. But in terms of the zoster vaccine, if an individual has been exposed through natural infection in the past, for the most part, is safe. The question comes into when somebody had shingles, clinical shingles, and I always give this example. Your immune system is already been re-exposed to the virus. So by having the clinical shingles, you are already inducing a refresher in the immune system to remember how to protect against the recurrence of these viruses. So the question becomes, is that actually necessary? That's a different question. But in terms of safety, when somebody has been already exposed in the past, the risks are minimal.
Thank you so much. So this next question is for Dr. Schreiner. It says, should my child be vaccinated? And given that I had a reaction, and then she notes that that her daughter is vaccinated, but that she's always nervous on how she will react to them.
Okay, so if I interpret that correctly, the person posing the question has been affected by a neuroimmunologic disorder like TM, and the question is, should her daughter continue to be vaccinated? So I would say yes. I know it is anxiety provoking to think about a loved one, a child, having a reaction that to a trigger that has caused a sequelae, a negative event in that person herself. But I think it's important to think again about how complex our immune systems are and how many factors go into causing a particular disorder like TM. So to sort of revisit what we talked about before, there are probably genetic triggers. We can't change our genes. They are the blueprints of our body, including our immune system, and they may have a predisposition towards inflammation. Our environmental factors, however, are going to vary significantly from one person to the next, even within a family. So a mother to a daughter may still have very different environmental exposures throughout their lives, customizing and training their immune system. And so just because one person in a family has had a reaction to a particular vaccine, that does not imply that other people within the family will have the same effect. And the benefits of vaccination are great. And I think we've seen in recent years, unfortunately, a resurgence of some diseases that had previously been controlled by vaccine, like an outbreak of measles at Disneyland. There's been an outbreak of mumps in Iowa, I believe. So these are vaccine preventable diseases that have, unfortunately, had a resurgence because a portion of our population is not vaccinating anymore. And this is risky. Then it introduces the possibility of so if the daughter in this situation were not to be vaccinated and she were to come into exposure to one of those viruses that was previously well controlled, but now because of lack of vaccination has got a foothold in our population again, she could become very, very ill from that disease. And I think it is worthwhile remembering that some of these diseases are much more than just a rash, and they have caused death and significant sequelae in the past. And so my summary is that yes, I think the child should be vaccinated.
Thank you very much. So thank you both. You have given us some really wonderful information on vaccines. And we had another question asking if there is any reason to space out vaccinations. So Dr. Mayorali, if you could answer that question.
I'm sorry, a reason to do what?
Yeah, to space out vaccinations.
Oh, no, the only reason being, as we mentioned before, if somebody's receiving an immunosuppressive therapy and we can eventually wait for the immune system to be restored to baseline levels before vaccinating. But other than that, as Dr. Schreiner mentioned, for the most part, the reason why these vaccines are given in these predetermined intervals is because that's been shown to be the most effective way to prevent disease. So for the most part, we try to adhere to the calendar. And just to second on what Dr. Schreiner mentioned, when you go through medical training, one of the first things you learn is that the first and foremost important role of physicians and healthcare providers is to cause no harm. And that's the last thing we want to do in our patient population. So do not harm is always in our minds when we recommend any type of interventions, including vaccines. So it's difficult sometimes to weigh the well-known and well-established benefit in communities of vaccination as a way to prevent disease versus these isolated cases that perhaps the vaccine had a role, not as causality, but a role in perpetrating or activating an already autoreactive immune system. The question is, do we need to generalize that into now recommending no vaccinations? Well, it's difficult. I don't, for the most part, don't recommend to stop vaccinations. And what I try to do is, on an individual basis, look into what are the potential risks that we can determine, and then try to work around that individual patient.
Yes, and I can speak to this question as well. So as a pediatric neurologist, I'm oftentimes asked this question. You know, a pregnant mom will say, you know, I'm about to have a child, and I know there are, you know, 6 different vaccinations that are required at 2 months, at 4 months, and again at 6 months. You know, is there any reason not to spread them out, so that instead of giving, you know, 6 immunizations on one day every 2 months, maybe we give 3 every month for 6 months? And I don't think there is a reason not to do that. I think the most important thing is getting the vaccines. But I think one of the downsides of spacing out, you know, at least those early vaccinations is you know, your infant is getting poked twice as often, or however many times greater number of pokes in order to get the immunizations. So I don't know if that was maybe the question that this person had, but I think I'll say there are some rules about how vaccines need to be spaced out. You know, the hepatitis B vaccine is given at birth, and then you have to have a second dose this many months later and a third dose between this many months later. So there are some rules that are, you know, created by the CDC to try and maximize the efficacy of the series. But is there a downside to spreading out vaccines in an immunocompetent patient? No, I don't think there's a downside.
Okay, and then, you know, just are there any particular, you know, side effects or benefits of vaccinations for people with rare neuroimmune disorders? For example, you know, the potential for something like autonomic dysreflexia, or, you know, worsening of symptoms after the vaccine, or, you know, for example, also helping make sure that people don't get sick who have, you know, whose ability to cough is impaired, for example. So if you could just speak a little bit about specifically in this population, you know, what the potential side effects or benefits could be.
Sure, Terry, if you want, I can take that.
Sure.
Basically, look at vaccines as a way to challenge the immune system, and if an individual already has an autoimmune disorder, the immune system is going to be susceptible to anything that will trigger activation of their cells, whether it's an infection, whether it's a UTI, whether it's a flu, or whether it's a vaccine. But I want to emphasize what has been said before, that when you look at the overall risk-benefit of vaccination, is still the most powerful way that we have to prevent infections. And even in the rare but possible case of the vaccine causing similar symptoms to the infection you're trying to prevent, for the most part, those symptomatic side effects of the vaccines tend to be a milder form of what could have been the symptoms from the infection you're trying to prevent. So for the most part, and you mentioned actually a perfect example of that, is somebody has significant disability that it has what we call bulbar symptoms, in which swallowing, coughing, it's impaired, imagine if that individuals develop pneumonia or infections on the respiratory airway system. The consequences of that and the complications are greater. So for the most part, again, we are sensitive to the potential risks, but we are still, for the most part, recommending vaccinations for individuals at risk.
Yes, and I agree. I will add that for people who have suffered any insult to the nervous system, following a vaccination, they may develop a fever. They may have what we call recrudescence or reappearance of symptoms that they have had before. So they might have a temporary worsening in the immediate period after the vaccine. That is, similar to, patients with multiple sclerosis being very susceptible to heat and having a temporary worsening in those situations. So there may be, in the short period after vaccination, for someone who has had a rare neuroimmunologic disorder, there may be return of prior symptoms, but that is temporary. And I, again, will reiterate that I think the benefits of vaccination to prevent illness in this population outweighs the risk.
Okay, thank you both so much for your time today. We're unfortunately, at the end of our time, but we hope to continue this conversation in various forms in the future. But thank you both very much for your time. We really appreciate it.
You're welcome.
Thank you for the invitation.
Thank you for the invitation.
And just to announce to our listeners, we will have another podcast next month. It's Managing Your Health After a Rare Neuroimmune Diagnosis, and we should be sending information about that shortly. And then there's also all of these podcasts are available on our website in our resource library at myelitis.org. So if you missed part of this time, you can always tune back in and listen to the recordings. So thank you.